Hello, everyone. Welcome to the ASG Guideline Podcast. I am Thosani, the chair of ASG Standard of Practice Committee, and today I am joined by my good friend Dr. Jorge Machicado. Today we will be discussing our latest guideline titled ASG Guideline on Management of Benign and Malignant Colorectal Stricture. Thank you, Dr. Machicado, for being here and leading this guideline.
Thank you, Dr. Thosani, for the kind invitation to discuss our guideline. It was a huge honor to participate and lead this effort together with the ASG Standard of Practice Committee. We conducted extensive systematic review and meta-analysis to produce this guideline on the endoscopic management of colorectal strictures.
Excellent. Dr. Machicado, I believe this is a very important guideline, especially in a context of rising incidence of early age, early onset colorectal cancer. And I believe we as a gastroenterologist will likely going to see colorectal stricture in younger patients. So I think this is very timely and this is going to help a lot of practicing gastroenterologists in managing their patients. So let's discuss a little bit more about these guidelines in detail. Can you walk us through what is the scope and purpose of this updated ASG guideline on colorectal stricture management?
Absolutely. This guideline addresses the role of endoscopy in the evaluation and management of both benign and malignant colorectal strictures, with a focus on evidence-based recommendations using a great framework where comparative evidence was available. It updates prior ASG guidelines by incorporating newer evidence on endoscopic management of colonic obstruction and strictures. This guideline focuses on five major areas. First, initial assessment of colorectal strictures, including imaging, endoscopic evaluation, biopsy, and tattooing. This part was conducted without great methodology, and we review the evidence and review as a panel to put up best practice advisors. Second, management of malignant colonic obstruction from potentially resectable colorectal cancer, particularly the role of colonic stents as a bridge to surgery. Third, management of malignant colonic obstruction from unresectable colorectal cancer. Fourth, management of malignant colonic obstruction from extracolonic malignancy, such as ovarian cancer, prostate cancer, lymphoma, or peritoneal carcinomatosis. And finally, management of benign colonic strictures, including endoscopic balloon dilation, colonic stenting, and endoscopic stricturotomy. A key theme is that management should be individualized based on etiology, acuity, stricture characteristics, surgical candidacy, oncologic plan, local expertise, and patient preferences. The guidelines also emphasize multidisciplinary management, especially in patients with partial or complete colonic obstruction.
Thank you very much for giving this detailed overview that what this guideline encompasses. Now, maybe let's take a deep dive into the guideline. Can you walk us through when we have a patient who has a malignant colonic obstruction, especially from colorectal cancer? How should clinicians choose between colonic stent or surgery?
Thank you, Nirav. The main question should be the role of colonic stents will depend largely on whether the colorectal cancer is potentially resectable or not. Starting with patients with potentially resectable colorectal cancer, particularly those who have left-sided malignant obstruction, the guideline makes a conditional recommendation favoring endoscopic placement of self-expandable metal stent as a bridge for elective surgery in patients who are appropriately selected. Compared with emergency surgery, colonic stents as a bridge to surgery was associated with higher odds of primary anastomosis, lower rates of ostomy, fewer postoperative complications, and we did not find any difference of mortality at 60 days or 3 years. However, the guideline highlights important caveats. Colonic stents were associated with a higher observed risk of cancer recurrence in the meta-analysis that we conducted, but the certainty of the evidence was very low for this association. This is probably explained because colonic stents carry a clinically significant risk of microperforation and overt perforation. And therefore, patients should be counseled about a trade-off between reducing the likelihoods of permanent ostomy and the uncertain but possible risk of cancer recurrence or perforation with colonic stents. Second, for patients with unresectable colorectal cancer, the guideline also makes a conditional recommendation favoring palliative colonic stent placement over palliative surgery. Compared with surgery, palliative colonic stent was associated with lower likelihoods of permanent ostomy, shorter hospital stay, fewer adverse events, and again, no difference in mortality. A major caution on this guideline is the use of bevacizumab or other VEGF inhibitors because there's a potential concern of increased risk of perforation related to the metal stent and complicated surgical rescue if perforation develops in these patients. And therefore, the guideline recommends shared decision making among the different subspecialties such as GI, colorectal surgery, oncology, and the patient at the center when we consider colonic stents in patients receiving bevacizumab.
Excellent. I think it's very important for viewers to know that when we develop this guideline, we developed this with a multidisciplinary team. It was not just a gastroenterologist in the guideline panel, but we had a representative from colorectal surgeons. We also had oncologist as well as a patient representative, and everybody weigh in different options. And then after extensive discussion and review of this literature, that's how we came up with these guideline statements. So we talked about colonic obstruction from colorectal cancer, but what about colonic obstruction that is caused by extracolonic malignancy? In those cases, what we do? Do we do colonic stents or do we should we consider surgical decompression?
Absolutely. For malignant colonic obstruction due to extracolonic malignancy, the guideline does not make a firm recommendation favoring colonic stent or surgery because of insufficient direct comparative evidence for this topic. Example of extracolonic malignancies causing colonic obstruction include again ovarian cancer, peritoneal carcinomatosis, and other metastatic diseases. Since the evidence is limited and no studies directly compare colonic stents with surgery, we rely on indirect evidence that compare colonic stent outcomes in patients with extracolonic malignancy versus intracolonic malignancy. The available data for that show that placement of stents for extracolonic malignancy is feasible, but less successful than those who have colorectal cancer obstruction. In pooled data, we found that colonic stents for extracolonic malignancy had adverse events up to 29% as well. So compared with a stenting for intracolonic malignancy, colonic stents in the setting of extracolonic malignancy have higher odds of technical failure and clinical failure as well. Reason for this includes the angulation that we sometimes find in this stricture, extrinsic compression, multifocal strictures, redundant colon, and difficulty advancing a guide wire or a stent delivery system. Therefore, the guideline recommends an individualized approach when we decide this, considering tumor biology, expected response to chemo, radiation, life expectancy, performance status, the location of the stricture is very important with multifocality, length, and angulation, and as well the presence of carcinomatosis and surgical candidacy. For many patients with advanced extracolonic malignancy and limited performance status, avoiding surgery and ostomy is going to be likely desirable. However, clinicians should counsel patients that colonic stents in this setting is likely to succeed, but it carries a higher risk of complications and technical failure as compared to colorectal cancer.
Yeah, thank you very much for highlighting this. I think it's very important for us to recognize there is never a one size fit all solution. And especially when colorectal stricture happens in a setting of extracolonic malignancy, definitely multidisciplinary approach, understanding tumor biology, location of the stricture plays a huge role in deciding what you are going to do for these patients. Now, let's switch gears and talk about benign non-inflammatory colorectal strictures because these are also very challenging in management of these patients and would like to know how does this guideline guide everybody between different options such as endoscopic balloon dilation, colonic stents, and also new emerging exciting method called endoscopic stricturotomy.
Thank you for the question. For
Mhm.
this, we also conducted a systematic review and meta-analysis, and the guidelines suggest endoscopic balloon dilation or colonic stents as first-line therapy. This was the first question that we addressed regarding a benign stricture. And this recommendation was in fact based on very low quality of evidence, but the direction is consistent with balloon dilation being overall more effective, less costly, more widely available, and associated with fewer adverse events than colonic stent in benign disease. In the synthesis of the evidence, balloon dilation had higher clinical success and lower adverse event rates than colonic stents. So for benign strictures overall, balloon dilation should be a first-line therapy. Patients should be counseled that multiple sessions are often going to be required. And the goal is typically to dilate to 80 to 20 millimeter over more than one session. And regarding colonic stents in this setting, the guideline does not support its routine use as first line. However, fully covered metal stents may be considered in selected refractory cases, but the migration rate remains a major drawback. And covered metal stents should generally be avoided for colonic strictures of benign origin. Now, regarding novel lumen-opposing metal stents, the guideline notes that this type of stents may be considered for carefully selected short benign strictures, particularly short post-surgical anastomotic strictures after the patient has failed endoscopic balloon dilation. However, available evidence does not support using LAMS as first-line therapy, and the migration rate remains a concern. Now, regarding novel technologies such as stricturotomy, the guidelines suggest endoscopic balloon dilation still over stricturotomy as first-line therapy. Now, stricturotomy may reduce recurrence in some non-randomized studies, but this benefit was not clearly sustained after adjusting for follow-up duration, and stricturotomy was associated with higher adverse events, particularly bleeding as compared to balloon dilation. The settings in which stricturotomy may be considered should be for patients who have a benign stricture less than 3 centimeters, those strictures that are fibrotic or non-angulated, refractory or recurrent symptoms after balloon dilation, and whenever there is a technical expertise available as well as surgical backup. In summary, endoscopic balloon dilation remains first line for benign colorectal strictures. Colonic stents, both cover and lumen-opposing metal stents, as well as stricturotomy, are adjunct or salvage options for selective refractory cases. And that guideline does not advocate for routine use of these therapies at this point.
Ore, thank you very much for very nicely summarizing and outlining all this complex decision making in both malignant and benign colonic stricture. But let's talk about what are the best practice advices does this guideline provide For initial evaluation, endoscopic assessment of this colorectal strictures, how we should biopsy, where we should put a tattoo, should we put a tattoo or not? There are a lot of questions that maybe we cannot address based on randomized control trials, but we still need some guidance that what is the best practice and what should be our approach.
Thank you, Nirav. So this section, again, was not developed using formal grade methodology, but instead, we use the best available evidence and the expertise of the panel to inform this. So key points include, with regards to the initial evaluation, we should assess for red flags that require emergency surgery, including peritonitis, hemodynamic instability, sepsis, lactic acidosis, ischemia, pneumatosis, or free air. These circumstances, again, endoscopic management will be very limited, and we need the expertise of our surgical colleagues. Cross-sectional imaging with CT or MRI should be used to define the obstruction site, severity, upstream dilation, and the likely etiology prior to embarking to endoscopic management. And surgical consultation is recommended for partial or complete obstruction prior to us trying to tackle these procedures. With regards to the endoscopic examination, if endoscopy is appropriate, we want to avoid air insufflation and use water irrigation preferentially to minimize distension. Now, the endoscopy should document the stricture, whether it is transversable, the distance from the anal verge, the length of the stricture if possible, as well as the diameter and the morphology. And associated features such as a mass, ulceration, inflammation, angulation, or diverticular should all be reported. In addition, there should be photo documentation in order for taking future decisions in case that we are not doing any therapies at the moment. Now, with regards to biopsies, if malignancy is suspected or the stricture is related to IBD, the guideline includes obtaining approximately 6 targeted biopsies, and this is again informed by prior studies. And biopsies of anastomotic strictures are generally unnecessary unless there's suspicion for recurrence of malignancy. Biopsies inside the diverticula should be avoided because of the perforation risk. Finally, with regards to tattoo placement, tattoo should be considered when surgical localization is needed, particularly for suspected or confirmed malignancy if a stent is not going to be performed. Carbon black is preferred in these settings, and the tattoo should be placed 3 to 5 centimeters distal to the lesions, ideally in 2 to 4 quadrants, with careful submucosal injection and documentation again of the report with photographs if possible.
Excellent. Jorge, thank you very much for very nicely summarizing all the best practice advice. I believe this guideline will be very, very useful for all our colleagues in managing their patients. On behalf of ASG, I would like to thank all the viewers, and I would especially like to thank our content experts who help us design this guideline, as well as all the members of ASG Standard of Practice Committee. Thank you very much.
Thank you, Nirav.